So one teaching point to make about papillary carcinoma is that echogenicity is often the key finding, whether it's cystic areas or microcalcifications or increased echogenicity. So that trumps just about every other finding. Now, the reason that sonography has emerged as the technique of choice to evaluate patients with papillary carcinoma is the ability with high-resolution transducers now to see these subtle microcalcifications, subtle areas of cystic change, and contour irregularity. And in addition to the features we've already mentioned, such as loss of the normal echogenic hilum and increased nodal echogenicity, these are very specific features. And when we look at the data on this, it's quite impressive. Here's an example of 198 nodes in 112 patients, published in JUM by Rosario et al. And look at these specificities. If there's internal cystic change, 100% specificity. Calcification, again, 100% specificity. So really a very specific technique for evaluation of cervical lymphadenopathy. Now, one of the reasons that ultrasound is so helpful in terms of guiding biopsy is we can define the areas that are going to be most fruitful to direct our needle. And here we can see the cystic change in the upper pole of this lymph node telling us it's a metastatic node involved with papillary. But of course, we wouldn't want to biopsy that area. We would want to direct our needle to the solid vascularized portion. Similarly, in this patient with extensive intranodal cystic change, you do not want to be aspirating simply the fluid components. You want to direct your needle towards the central area that has multiple calcifications. Similarly, in this patient, the mid and lower pole has cystic change, the upper pole is more solid, and here we can see examples of increased echogenicity, cystic change in a very abnormal lymph node. Another example where there is more focal cystic change, again, we would want to direct our needle away from that. Now, occasionally in patients that have suppurative lymphadenitis, you will have abscess formation. This was such a patient who had a chronic infected lymph node, and we aspirated this and sent it for culture and sensitivity. So cystic change in the lymph node may be related to infection in the appropriate clinical setting. Generally in the patients who are post-thyroidectomy and for papillary cancer, that's not a clinical concern. Here's a really nice example of increased echogenicity, markedly abnormal node. We can see their focal microcalcifications. And here's a more confluent area of calcification. So sometimes these calcifications sort of aggregate and may cause acoustic shadowing. So any calcification at all is always circumspect and always very suspicious for metastatic papillary cancer, whether it shadows or not. Some of the nodes are dramatically hypervascular, and here is a patient. Actually, the thyroid gland was completely normal in this individual, and a thyroidectomy had only a 2 millimeter carcinoma, yet presented with a neck node. See how strikingly echogenic it is and how strikingly vascular this is. We'll make the point when we talk about biopsying highly vascular lymph nodes that we have to use a capillary technique rather than a suction technique, or we'll just get blood. So in papillary carcinoma, the echogenicity of metastatic nodes is often different than the primary cancer. Most primary cancers of the thyroid tend to be hypoechoic. And here's an example of a lesion that's taller than wide. It has discrete margins, has increased flow, typical thyroid cancer. Here's another patient, taller than wide, hypoechoic thyroid cancer. But the lymph node is markedly different than the primary tumor. Notice that the lymph node is now echogenic, and despite the fact that no microcalcifications were seen in the primary tumor, it's just loaded with microcalcifications. So don't require that the neck nodes look the same as the primary. Here's a patient with a primary cancer in the thyroid, and just immediately adjacent to it, the cystic nodal mets has an extensive cystic change. So again, there's often quite a discrepancy in the echogenic appearance of nodes versus primary cancer. Here's a solid papillary carcinoma that has calcification and yet extensive cystic change within the nodal mets. Now, we've made the point that the normal Doppler flow pattern is a central pattern that's often very minimal in normal patients. And here you can see increased echogenicity. Notice how rounded the nodes are compared to the strap muscles. These nodes have increased echogenicity and have really a striking degree of peripheral flow. So here's an example where the color Doppler and the morphology and echogenicity all point to abnormal lymphadenopathy. And these are nodes that are just stacked up each other in level 3 along the jugular vein. And here we can see these hypervascular lymph nodes on a contrast-enhanced coronal and sagittal CT, and you can see how vascular they are. Notice again on the color Doppler examination of these two patients, some of these nodes have real spotty areas of increased vascularity. You will not see increased flow in cystic areas within the node, and so again we want to direct our needle to the solid vascularized portion of the lymph node. Here's just another patient with chaotic flow pattern. It's often quite hard to give morphologic descriptors of the flow patterns. It's just that they look very different than the very subtle central pattern. So any deviation from that central pattern should be considered abnormal. So when biopsying these nodes, direct the needle away from cystic areas and towards areas of visible blood vessels. However, if there's a lot of vascularity within the lymph node, we want to first use an aspiration technique. This is an example of a patient who has a very large lymph node in the right neck, microcalcifications. This was biopsied at an outside institution several times with no adequate cytology. And here we can see the reason for that is that the area of the node that shows dramatic increased flow is quite vascular, and we would only get blood. So we directed our needle away from that node. In this case, we could use a suction technique because we're going into solid tissue, but it wasn't richly vascularized. It's sort of a window of decreased vascularity. And here you can see on the cytologic specimen the sort of papillary frond-like nature of papillary carcinoma. Now, when we're referred patients with head and neck cancers, particularly when it's squamous cell carcinoma, often these nodes have a striking degree of central necrosis. And here, head and neck gadolinium MRI, notice that on the right, one of them is homogeneously enhancing, but the more anterior node has extensive cystic change. So with squamous cell carcinoma, because of the cystic appearance, and here's just another example on now a T2-weighted sequence with fat suppression, how cystic these nodes can be because of the extensive central necrosis. So when presented with a patient either with squamous cell or with papillary carcinoma that has extensive internal cystic change, the key here in terms of making the diagnosis is to direct the needle to the solid peripheral tissue. And so you want to go towards the periphery and not centrally. And here's another example comparing the ultrasound to the contrast-enhanced MR. And it's often very good to be looking at the MR at the time of biopsy to sort of map out in your mind exactly where you're going to put the needle. And here's another example of extensive cystic necrosis, but you can see there's a little portion of solid tissue more medially, and that's where you need to biopsy. And in general, you will get much more cellularity in biopsying the peripheral portion of a lymph node. And here's such an example, previously biopsied in an outside institution, negative results. And you can see, although the node looks uniform, there was central necrosis, and we can't always see it because we don't have contrast agents as we do in head and neck CT and MR. And here's the example of showing how the needle is on the periphery. Now, if you're presented with a node that's got extensive cystic change and one that's very vascular, and to biopsy these lymph nodes, you need to take a different approach. You know, we can be successful biopsying cystic nodes if we direct the needle in the solid portion, and we would use the suction technique because this tends, depending on the vascularity, if this wasn't particularly vascular. The point being is we would not want to direct our needle in the cystic portion of the node. Similarly, these hypervascular, these are small nodes, but they were positive. They can be biopsied successfully, and the point being is we want to use a capillary technique, not a suction technique. We'll just get blood if we use a lot of suction. So it is possible to do FNA of less vascular nodes, and we have to know when to do suction versus capillary, and it really depends on the degree of vascularity. Let's talk a little bit about the post-thyroidectomy patient and using ultrasound to look for recurrence, either at nodal sites or in the thyroid bed. And if we're talking about the thyroid bed, we want to pay strict attention to any hypoechoic tissue, particularly if it's vascular. And biopsy should be considered for lesions that are 5 millimeters or greater. And in general, they tend to be hypoechoic, Occasionally you see microcalcifications, and a lot of them we found have increased flow. So here's a typical patient that has recurrent papillary carcinoma within the thyroid bed, and here you can see we're directing our needle into this recurrent mass, and this is proven to be papillary carcinoma in the thyroid bed. And again, we can see another hypoechoic nodule in the echogenic fibrofatty tissue. If we can see it, we can direct our needle into it. And here's an example of actually going to the operating room and performing an intraoperative ultrasound to biopsy this lymph node and to guide the surgeon intraoperatively. Color can be very helpful in looking for a variety of thyroid bed recurrences. And here's an example of very subtle increased thickening of the soft tissues around the trachea. We can see subtle widening of the trachea here. And with increased flow, we can see that there is a more clearly evident hypoechoic soft tissue mass that is really richly vascularized. And this is an extensive recurrence that's invading the trachea. And the hallmark is hypoechoic tissue that's richly vascularized.